Good morning. My name is Julie Hawkins, Events Manager here at Winship Cancer Institute. Thank you for joining us this morning for Winship Grand Rounds. If you're an Emory University or healthcare employee and would like to receive a CME credit hour for attending today, the login information will be found in the chat feature on the bottom of your screen. If you have any issues with this webinar or the CME login, please send me an email or drop me a note via the chat feature. This morning, we are excited to welcome Dr. Eileen Connolly. Dr. Connolly is an assistant professor of radiation oncology at the New York Presbyterian Columbia University Medical Center, specializing in breast malignancies. She was recruited as a physician scientist within the Department of Radiation Oncology and has a translational research laboratory in the Center for Radiological Research at CUMC. This enables her to pursue her research interests in understanding the response of tumor microenvironment to high-dose radiation. Specifically, her research focuses on how HDRT affects the tumor microvasculature and endothelial notch signaling and what impact that has on immune cell recruitment. Clinically, she has developed a number of collaborations with both the breast medical oncologists and breast surgeons to improve both the delivery and efficacy of radiation to their shared patients. These include the development of intraoperative radiation therapy program for early breast cancer patients, as well as investigating more intensive therapies for locally advanced breast cancer patients who have less than a complete response to neoadjuvant chemotherapy. In 2014, she received the KL2 Mentored Career Development Award, and through this award, she received an MS in Biostatistics in the Patient-Oriented Research track at the Mailman School of Public Health at Columbia University. In addition to the KL2 award, she's received a number of small pilot grants, including a 2017 Avon grant, to open an investigator-initiated prospective study on the use of IORT for DCIS. In 2016, she received a research grant from Merck for an investigator-initiated window of opportunity trial of pembrolizumab plus IORT in early-stage triple-negative breast cancer, from which they hope to investigate biomarkers of response to immune therapy and TNBC. In addition to her own investigator-initiated trials, she is the CUMC site PI for a number of Alliance and NRG breast cancer trials, as well as the Target US Registry trial of IORT for early breast cancer. She's a member of the Breast Cancer Translational Research and Radiation Oncology Committees of SWOG, as well as member of NRG Breast Cancer Translational Research Subcommittee as the Scientific Research Committee of ASTRO and the Target Collaborative Group Research Committees. Welcome, Dr. Connolly.
Thank you. So first of all, thank you, especially to Dr. Yu, who invited me to talk today. I'm going to be giving a clinical talk discussing the use of accelerated breast radiation, since there's a number of updates that have come out over the last few years, and talk a little bit about how I feel IORT fits in. So just briefly, my disclosures: I have some research support from Merck, as well as ESI on biomarker development, and some travel support from SICE. So just to run over the outline, I'm going to talk a little bit about the rationale for partial breast irradiation, what it is and why we are interested in it, what techniques exist, who are the patients that are selected, so what are the ASTRO guidelines, and then talk about the evidence that supports partial breast irradiation. There's a number of large randomized trials that have been reported over the last few years. And then we'll talk about IORT, specifically using the interbeam system, since that's where the most randomized data comes from with the Target A trial, the controversies, the future, and then conclusions. So partial breast irradiation, how did we get here? So there was an interest in this beginning in the 90s. As breast conservation became standard, there was evidence that demonstrated that the pattern of failure that was seen after breast conservation therapy was that the majority of patients would recur within the 80% would recur within the same quadrant as the initial disease. So, and that's where most of the failures that you would see. So there's this idea of maybe we don't need to treat the entire breast, maybe we can treat just the lumpectomy bed. So just one study demonstrating this was from Milan, where they had a randomized trial of breast conservation with or without radiation, looking at the pattern of failures. And majority, as explained previously, would occur within the lumpectomy bed, within about 2 centimeters from the scar. So that sort of introduced the idea of maybe the area of greatest risk is at the lumpectomy site. Additionally, the rationale is that if we could treat a smaller volume of the breast, perhaps there could be less toxicity. So looking at early brachytherapy data, the smaller the volume that was used for the implant, the less risk of severe breast fibrosis. So it also sort of reinforced, if we treat smaller areas, we're probably going to be able to do this with less toxicity. And finally, there's the whole concept that if we can if we can treat a smaller area, we can do it in a shorter amount of time, and thus could perhaps improve quality of life. And this could influence the decision for mastectomy, because there is still a significant amount of data that shows for women who live far from radiation centers that their choice to save the breast may be influenced by the distance they have to travel for radiation, the actual cost, as well as the lost time for work. And then based on the patient's age, some older women may just choose to undergo mastectomy rather than bother with radiation. And there's studies that have looked at the length of time that radiation takes can directly impact their choice. So if we can, again, treat a smaller area, we can potentially do this faster, and that would allow more women to choose breast conservation. So there are a lot of techniques for partial breast irradiation. So first of all, partial breast irradiation is radiation just to the lumpectomy bed with margin. Accelerated partial breast is really that the course is shorter. We're giving a larger dose per fraction, and we're shortening the overall treatment time. So those are two separate concepts sort of bundled together. There's a number of techniques, the oldest being post-operative techniques, so that women would undergo lumpectomy first, and then initially interstitial brachytherapy was the first technique that was developed, followed by external beam and cavitary brachytherapy or balloon-based brachytherapy that came next. And then there was an interest in intraoperative radiation, which was developed really in the late 90s, and there's a number of different methodologies for doing this. So there's obviously low-energy photon systems, which are the Zeiss interbeam system, as well as the Zoft Axion system. There's use of electrons through devices such as the Mobitron system. There's also HDR brachytherapy. There's other ways of doing this, but all done within the operating room. But overall, the key to this is that all of these different techniques are very heterogeneous. There's a lot of differences in the timing, the length of treatment, the actual physical technique, the physical properties, meaning how the dose is delivered, what the dose is per fraction, and the overall volume. So they're quite varied. So in the early APBI trials were mostly phase 2 single institutional studies, so not very large, but there was a number of them that had started to come out by the early 2000s. And in 2009, and again updated in 2017, ASTRO published guidelines to sort of guide who we could consider suitable for consideration of these more focal treatments. So essentially limiting it to women over the age of 50 with small tumors, negative margins. They did expand in 2017 to include DCIS. Cautionaries if you're between 40 and 49, or if you have any of these higher risk features, a larger size, LVSI, if it's hormone receptor negative, or lobular histology, or extensive intraductal component. And then DCIS, anything larger than 3 centimeters is unsuitable. And then with their updated guidelines, it's important to note that IORT, especially with KV photons, given the limited data, was indicated should only be done in the context of prospective registry or clinical trials. But so this is kind of where we stood in 2009, and then again updated in 2017. But now a lot of data has come out. So these are the large modern randomized trials. These are phase 3 trials testing partial breast irradiation, looking at local recurrence. And there's a lot of data here, and I'm going to focus on the most recent studies that have been published, starting with the Import Low trial, then reviewing B-39, the RAPID trial, and then more recently the Florence trial. These all give us a lot of data with using external beam primarily, and then finally talk about the Target trial in the most recent update. So Import Low is a really interesting study because what they did is it's a randomized phase 3 non-inferiority trial looking at partial breast irradiation, but they used standard fractionation. So they treated women in one of 3 cohorts: whole breast, which is 40 gray and 15 fractions, no boost was allowed, or reduced dose, meaning they gave a lesser dose to the entire breast with a boost to the lumpectomy bed concurrently, or finally partial breast irradiation, treating with the same dose, 40 gray in 15 fractions, the lumpectomy bed, which was defined as the postoperative bed with a 1.5 centimeter margin followed by another centimeter margin around that, and compared these 3 cohorts with a non-inferiority design, and the primary outcome was local recurrence. And they set their pre-specified non-inferiority margin at 2.5% at 5 years. And as I said, they used the same standard dose for each cohort. It was only the volume that was reduced. And this is showing who was eligible for the study. They were fairly conservative. It involved only invasive tumors, women over the age of 50, and tumors that were less than 3 centimeters in size, though all grades were allowed. And technically, node positive was allowed, minimally node positive disease, and you had to have negative margins. And when you look at who was actually recruited, overall, it was a fairly low-risk cohort, as you'd expect, when median age was about 60, small tumor size, majority were grade 1 or 2, most were node negative with no LVI, and most were hormone receptor positive. So this is a low-risk cohort overall. And their 5-year local relapse was recently reported in 2017. They had a median follow-up of 6 years, so most patients, about 80% of patients had 5-year complete follow-up, and they show that local recurrence, or same breast recurrence, with whole breast was 1.1%, with reduced dose was 0.2, and with partial breast was 0.5%. So essentially there was no statistical difference, and they were able to meet their primary outcome of non-inferiority. Now, their secondary outcomes showed no difference between groups in terms of local regional relapse, distant relapse, disease-free survival, or overall survival. And then, importantly, they were interested in the cosmetic outcomes. So was there any difference if you treated just part of the breast? You'd be concerned that maybe it would cause partial fibrosis within the breast that would affect the breast shape or size. And they did a really nice job of looking at this. They did patient-reported outcomes, physician assessment, and a photographic sub-study, and looked at both discrete time points over the 5-year course of follow-up, as well as the cumulative incidence, and essentially found no difference between any of these groups. There was perhaps slightly less acute toxicity in the partial breast irradiation, but as far as long-term toxicity and cosmetic outcome, they were completely similar. So it answers the question that if you treat just part of the breast, you're not affecting the cosmetic outcome. And what differences we see later are more likely due to the dose and the fractionation schedule that was delivered. So their conclusions are partial breast irradiation is non-inferior to whole breast irradiation for early breast cancer, so well-selected patients. There's equivalent or perhaps fewer normal tissue adverse effects with partial breast irradiation. And importantly, the dose and fractionation was exactly the same as the standard whole breast irradiation. They only tested the hypothesis about volume of breast treated. But this is important because it kind of sets that as, sets that standard. Now, moving on, the RAPID trial published in 2019 was a Canadian study that randomized patients to either standard whole breast irradiation or accelerated partial breast irradiation, and everyone got 3D conformal radiation. So the accelerated regimen was a total dose of 38.5 gray given in 10 fractions twice a day over 5 days. And this was compared to whole breast irradiation, which could be either conventional fractionation 50 and 25, or hypofractionated 42, 56, and 16, and a boost was at the discretion of the treating physician. Their primary endpoint, again, was local recurrence in the same ipsilateral breast tumor recurrence, and this was a non-inferiority trial design as well. And they pre-specified their non-inferiority margin at 5 years as 1.5%, meaning that APBI could be no worse than 1.5%. With the confidence interval compared to whole breast irradiation. They recruited patients from 2006 through 2011 and now reported data with a median follow-up of 8.5 years. And this regimen, importantly, is the same as what was used in external beam for B-39, which we'll talk about later. So their patient cohorts that were, who did they recruit? So again, this was very similar to what we saw with the import low study. Median age was 61. It was majority was invasive disease, so they did allow DCIS, and they actually recruited 18% of their patients. The tumors were small, majority less than 1.5 centimeters. Most were hormone receptor positive, and most patients got endocrine therapy. 82% of the women who got whole breast, majority of the whole breast patients actually got hypofractionation. So it was 80% of those patients, and only 20% got a boost. So that's important for the cosmetics outcome data. So as far as their primary aim, ipsilateral breast tumor recurrence, they found that APBI was non-inferior to whole breast irradiation. At 5 years, the incidence of recurrence was 2.3% versus 1.7%, and they met their pre-specified non-inferiority margins. So they could state that it was non-inferior at 5 years. When they did a post-hoc exploratory analysis, essentially trying to look for risk factors that might predict that one regimen is better than the other, either favoring APBI or favoring whole breast irradiation. The only thing that really seemed to cross the threshold was tumor size, and this is exploratory, but it's still interesting. So it's saying that tumors bigger than 1.5% might do better with whole breast irradiation, but obviously more data would be needed to know that. So their secondary outcomes, no difference in overall survival, in disease-free survival, or event-free survival. So this is important because it suggests there's no negative effect of giving this accelerated partial breast irradiation with respect to systemic recurrence in this patient population. And this is just the granular data of, what events that they saw later. There was no difference, significant difference in contralateral breast cancer or death. What differences they see in secondary cancers overall they felt was just related to chance. And now, importantly, toxicity. So they looked at both acute and late toxicity with physician and patient-reported outcomes, as well as photographic assessment. And what they saw is that the acute toxicity, whole breast irradiation, was slightly worse. They saw a higher rate of grade 2. They felt that this was related more to the total dose received rather than the fraction size. But then when you looked at the late toxicity, they saw a significant increase in tissue fibrosis and skin telangiectasia with APBI compared to whole breast irradiation. And when you looked at the cosmetic outcome, and this was done using photographic assessment as well as patient and nursing reported outcomes, they saw a significant worse cosmetic outcome with an increase in fair outcome, rating of fair compared to excellent or good in the APBI arm compared to whole breast irradiation. So their conclusions are that APBI is non-inferior to whole breast irradiation in preventing local recurrence. And the overall local recurrence rate was very low with a very small absolute difference between arms. However, APBI, at least this fractionation regimen, was associated with more late toxicity. So, and because of this, they do not recommend the twice-a-day regimen. Now, the comparison arm here, again, the majority of those patients who got whole breast irradiation got the short course, and only about 20% received a boost, which is important to think about with the next trial's data regarding toxicity. So the next study that came out at the same time was B-39. It's, again, a randomized phase 3, and this was an equivalence trial comparing APBI to whole breast irradiation. And they had a broader entry criteria. They allowed a broader range of patients. So up, DCIS, stage 1 or stage 2, tumors up to 3 centimeters in size. And no more than they allowed node-positive disease with no more than 3 positive nodes. Their primary outcome, again, was ipsilateral breast tumor recurrence. However, this was an equivalence trial. So they were trying to prove that APBI was equivalent to whole breast irradiation, fitting within the confidence interval. And they pre-specified a 50% increase in relative risk is acceptable. So this is their hazard ratios that they wanted to see. And they allowed in their APBI arm 3 modalities for partial breast irradiation: multi-catheter brachytherapy, mammocyte balloon catheters, or whole breast irradiation following the same regimen as the RAPID trial. And all of them were given twice a day. So they recruited a little over 4,000 patients from 2005 to 2013, and they reported their 10-year data in 2019 with a median follow-up of 10.2 years, with over 98% of patients with complete follow-up information at that point. And 80% of the patients who got whole breast irradiation did get a boost. And it's important to remember here, all the patients who got whole breast irradiation got standard conventional fractionation, so 50 gray and 25, or 50.4 and 28 fractions, and then most got a boost. APBI, they used 3 different modalities. Majority got 3D external beam planning, so 73%. 21% got balloon brachytherapy, and 6% got multi-catheter brachytherapy. And there was not enough power to detect differences in outcome with APBI between these techniques. So their patient characteristics, because they had a broader entry criteria, which was done on purpose so that they could look at how APBI performed in a wider cohort of patients, they had a lower median age. It was 54. They actually allowed any patient over the age of 18 into the trial. So there are actually very young women who are enrolled. Most are still hormone receptor positive, but a larger cohort received chemotherapy, and they had a larger proportion of DCIS patients, with 24% of their patients having DCIS, which is interesting. This risk group gives you the breakdown based on ASTRO risk categories. So, there was the low risk is considered the suitable category. Other invasive is basically the cautionary or unsuitable based on ASTRO guidelines. So you can see that they had a larger amount of patients who would be considered cautionary or unsuitable compared to the other trials. So what is their in-breast tumor recurrence? So this is their primary endpoint at 10 years. They saw 161 in-breast tumor recurrences, 90 in the APBI arm versus 71 in the whole breast irradiation. So the absolute difference was extremely small. It was 0.7% at 10 years. But it did not meet their primary outcome. So APBI is not equivalent to whole breast irradiation based on the upper limits of the hazard ratio. So they set their confidence interval. So this is just kind of to explain what happened here. Essentially, they set a pre-specified margin of equivalence for APBI compared to whole breast irradiation. And because their study, the lower bound actually crossed the pre-specified 1.5 hazard ratio, they could not state that APBI was equivalent to whole breast irradiation. Now, comparing this just to the RAPID trial, just for reference, in the RAPID study, this was a non-inferiority study. So instead of focusing on both the upper and lower bounds, you focus, instead of being two-sided, this is a one-sided t-test, and you're looking at whether it crosses a pre-specified non-inferiority margin. And in the RAPID trial, they actually set their margin of acceptable non-inferiority slightly lower. So even though their confidence interval is wider, they had a positive outcome stating that APBI is non-inferior to whole breast irradiation, whereas B-39 did not meet their primary outcome and could not state that it's equivalent. However, the outcomes are actually very similar. As far as their secondary outcomes, there's no statistical difference between recurrence-free survival, distance-free survival, or overall survival that was observed in this cohort. And overall, there was very good outcomes. They, again, also did an exploratory post-hoc analysis. So, again, trying to look at what features might predict favoring APBI over whole breast irradiation or vice versa. And, again, size is the only thing that sort of crossed. It's in an interesting finding. I think more work needs to be done with this. But if you look, the greater than 2 centimeters also, crossed the line. So, and then interestingly, what I think is important, is when you look at the ASTRO guidelines of low risk versus the other categories, neither one seemed to favor APBI versus whole breast irradiation. And then I think it's interesting to look at DCIS. It didn't, it was right, neither APBI or whole breast irradiation was favored. So I think that's interesting. And they had almost 1,000 patients with DCIS only, so that's an interesting finding. Now, regarding toxicity, the way they assessed toxicity was different than the RAPID trial. They assessed acute and chronic toxicity by the treating physician using the CTCAE measurements, and it was not done with patient-reported outcomes or photographic assessment at the end. And they documented baseline and then end of RT 1 month, 6 months, and annually thereafter. And they didn't report a difference. But what's not clear is if this is the aggregate score, if this is the maximum score that was seen, but they demonstrated no difference between APBI or whole breast irradiation. So it may have been the way they measured it. However, the whole breast irradiation was conventional fractionation, and most women got a boost, which is known to be a poor cosmetic outcome compared to hypofractionated radiation. As far as the other outcomes, no difference in incidence of secondary cancers, no difference in contralateral breast cancers, so those were other toxicities they investigated. So their conclusions are the pre-specified, they did not meet the equivalence criteria pre-specified for APBI to whole breast irradiation. However, their study, it was powered to detect equivalence in a much broader range of patients. So they had set a really high bar for themselves. And when you look at the absolute differences, it's really tiny. So I think it's really reasonable to say it's acceptable for patients similar to those in the other trials, that APBI is a reasonable option for those similar to those enrolled in the RAPID trial. And then they noted no difference in toxicity. However, given that this is the same regimen that was used in the RAPID trial, I'd be worried about late toxicity. Finally, the Florence trial. So this is a single institution study that compared whole breast irradiation to accelerated partial breast irradiation. However, they used a different fractionation schedule. They gave 5 fractions of 30 gray, so 30 gray and 5 fractions of 6 gray each, given every other day. So only 5 treatments every other day. And they allowed an IMRT approach to the delivery of radiation. And this was randomized against standard conventional fractionation, 50 gray and 25. And all women were actually required to get a boost in this study. And their primary outcome, again, was ipsilateral breast cancer recurrence, so true recurrence versus new breast cancers in the same breast. And their study was designed to compare the 5-year recurrence rate between APBI and whole breast irradiation, but it was not actually powered as a non-inferiority trial. So they had an expected rate of recurrence in whole breast of 5 years of 3%, and they had pre-specified equivalence if APBI was less than 5%. So they just recently reported this year their 10-year data. So as far as who they recruited, this was, again, a more conservative patient population. It was an older age group, 62. It was only invasive disease. There was no DCIS patients recruited. Most were hormone receptor positive. Less than 2% got chemotherapy. Most were node negative. And if you look by ASTRO suitability criteria, most were suitable with some cautionary and much less unsuitable patients. So this is a lower risk cohort compared to the B-39 study. And what they found now at their 10-year data is that the cumulative incidence was 2.5% for whole breast irradiation versus 3.7%. So they met their pre-specified aim that this was acceptable, and their overall recurrence rate was very, very low. And if you look at exploratory results, they tried to see if any suitability cohort was more favorable if they got whole breast irradiation versus APBI, and they actually didn't see any difference. So if you look at the cautionary unsuitable, the incidence of recurrence, I mean, overall it's very low, and there was no difference between whole breast irradiation and APBI. And then finally, as far as secondary results, there was no difference in local regional recurrence or distant metastases, and overall survival or breast cancer specific survival. And then as far as acute and late toxicity, so they did, again, a very good job here. They assessed using both physician-reported and patient-reported outcomes, looking at acute toxicity separately from late toxicity. And what they found is that the acute toxicity in both arms, APBI did better than whole breast irradiation with less acute and less late toxicity. And when you look at cosmetic outcomes, there was a better overall cosmetic outcome, and this was using the Harvard Aronson scoring system, which gave 4 categories: excellent, good, fair, or poor. And overall, there was more excellent and good in the APBI arm compared to whole breast irradiation. Again, though, they used conventional fractionation, and everybody got a boost in the whole breast irradiation. So maybe this wouldn't have been true if they'd used hypofractionation. So their conclusions: the 10-year cumulative incidence of ipsilateral breast tumor recurrence with APBI was very low and not significantly different compared to patients with whole breast irradiation, though not powered to prove non-inferiority. But given the RAPID trial, I think you can say that it is. Treatment-related toxicity and cosmetic outcomes were significantly better in the APBI arm, specifically delivered in this fractionation every other day, but they didn't look at APBI compared to modern hypofractionation regimens, and they actually stated in the paper that it perhaps would be different, and if you use field and field for dose homogeneity, they might also reduce the toxicity in the whole breast irradiation arm. So far, what can we say? I think we're safe to say that partial breast irradiation is non-inferior to whole breast irradiation for early breast cancer. There's over 8,500 patients that have now been recruited. Twice-day regimens are not recommended, and I think this is due to the toxicity compared to whole breast irradiation. However, the once-a-day regimen seems to give superior toxicity to standard fractionation whole breast irradiation, and this is the preferred fractionation regimen. It's what we use when we give external beam APBI. How does it compare to hypofractionation whole breast irradiation? That's not clear yet. And so who do we consider? I think it's safe to say that women over the age of 50 with small tumors, low grade, node negative, hormone receptor positive, excluding lobular tumors, they've clearly fit in all of these studies and seem to do well with APBI. It's very likely, I imagine, over the next few years, we'll see a revision in the ASTRO guidelines, since it seems like the ASTRO criteria of suitable, cautionary, or unsuitable doesn't really predict necessarily who's going to do better with one versus the other. So I think now, given all this data, they'll probably revise those guidelines. And I'm sure there's going to be a role for biomarkers. Oncotype has become very useful in looking at, the use of chemotherapy. It's being explored in terms of local recurrence for locally advanced disease. So I'm sure we're going to start seeing the exploration of biomarkers to help us better differentiate who's going to do better with less radiation, maybe no radiation. So that'll be interesting over the next several years. Given the small numbers overall of ER-negative patients, HER2-positive patients, and node-positive patients, I don't think that these should get APBI at this point. I think they generally should still receive whole breast irradiation. However, there's always exceptions, perhaps elderly patients where it's very difficult, and this kind of gives you that there is a benefit, but it's maybe not as good. And then we should use a lot of caution with women under the age of 50, because there's not a huge number of patients within this, but it's still possibly an option for patients with low-risk breast cancers. So now moving on, what about IORT? So IORT is a form of accelerated partial breast irradiation, as I said earlier. It's radiation delivered at the time of the lumpectomy in the OR. Using, this is, I'm going to focus on the low energy KV systems, which is the ZOFT and Zeiss systems, which are very similar. Those prescribe 20 gray to the lumpectomy surface using low energy photons, 50 kV. Which attenuate in their initial models to 5 to 6.5 gray at 1 centimeter depth. Treatment takes about 20 to 45 minutes in the operating room and is done while the patient is under general anesthesia. Now, as far as, the concern has always been with IORT that this dose is very, very low, and how much are we really giving to the lumpectomy bed? What's interesting is there's been a lot of new papers that have come out on this, and in fact, the dose might be higher than what we think it is. So first of all, with calibration, as the AAPM has tried to come up with standardization for IORT methodology for low energy photons. They've done studies looking at dose delivered at 1 centimeter, like overall dose that's delivered, and actually with measurements, it seems to be higher than what was initially reported. So it's probably more in the order of 6 to 7.5 gray for applicators between the size of 3 and 4.5 centimeters, which is most of the cases that are used. Additionally, when you look at the dose delivered, because you're in the low energy photon range, it actually has different properties compared to higher energy MV. So there's a higher RBE because you're looking at photoelectric effect, Auger electrons. They actually cause more direct DNA damage and have therefore a higher RBE. And this is an interesting paper that actually modeled it using different types of tissue to come up with DNA damage occurring at this energy range, comparing the ZOF system versus the interbeam system, and they gave an estimated RBE for adipose and glandular tissue of about 1.55. So this is what you'd expect in breast tissue. So in fact, that means that we might be delivering an equivalent dose somewhere closer to 9 to 12 gray, which kind of makes you feel a little bit better about the radiation that's being delivered, that this might be effective. Now, as far as data supporting it, so the only randomized trial for low energy photons is the Target A trial. So this was targeted intraoperative radiotherapy alone. It was a prospective randomized non-inferiority trial run from 2000 to 2012, enrolling women over the age of 45 with unifocal invasive disease less than 3.5 centimeters. And their primary endpoint was local recurrence, and it was a non-inferiority trial with a pre-specified non-inferiority margin of 2.5% at 5 years. Secondary endpoints was survival and complications, and this was a risk-adapted trial. So their workup, these women were selected preoperatively. They were worked up conventionally with mammogram and ultrasound. They did not require MRI, and only 5% of patients got one. It was risk-adapted because after the lumpectomy for the women randomized to IORT, based on post-pathology features, they may get whole breast irradiation. So the pre-specified requirements was that if the final path margin was positive, requiring re-resection, or very close, less than 1 millimeter, they were required to get whole breast irradiation. If there was extensive intraductal component, it was required, or if it was invasive lobular. It was not necessarily required if it was node positive or ER negative. However, they allowed individual institutions to specify their own requirements, which actually confuses the data quite a bit. The other thing that happened in this study that I think makes it very complicated is that in 2004, they expanded the trial. So a number of institutions were interested in IORT and wanted to participate. However, they did not feel comfortable randomizing women pre-operatively, so at the pre-lumpectomy. So instead, they wanted to have women undergo a two-step procedure, undergo lumpectomy, get final pathology, be deemed eligible, and then in a second procedure receive IORT. So this ended up becoming a second strata within the trial. So they ended up doing two strata, the pre-pathology group, which was randomization prior to lumpectomy, and then risk-adapted whole breast irradiation versus the post-pathology. And in the initial protocol, they actually specified that these should be analyzed separately. However, when the initial, I'll get to that in a second, how they analyzed it, however, was somewhat controversial. So who did they enroll? Overall, the patient characteristics, it was 45 was a requirement that be 45 or older, so 90% of the women were over the age of 50. Most had small tumors, and most were hormone receptor positive, though 20% did receive chemo, and when you look at it, 21% were node positive. So what were their results? When you actually looked at the patients enrolled, 2/3, the majority were enrolled in the pre-pathology trial, so IORT at the time of lumpectomy. But 1/3 of the patients enrolled, and most of these were in New Zealand and Australia, were in the post-pathology subset or strata, and they got IORT after lumpectomy as a second procedure. So this is about 1,100 patients. As far as risk adapted, of the entire cohort of over 3,000 patients, 15% did get patients randomized to IORT did get whole breast irradiation. As you'd imagine, most of those were in the pre-pathology cohort, those that were randomized prior to lumpectomy. So they reported their 5 years data in 2014, and it's a little bit confusing as to why they did this, but they reported the entire cohort at once, and they showed the 5-year local recurrence rate was 3.3% in the IORT group versus 1.3 in the whole breast irradiation group. However, their median follow-up was very short. It was only 2.5 years. And so less than half of their patients had actually gotten to 5-year local recurrence, which is a major flaw in doing this analysis at that time point. And, but they met their primary outcome, but a lot of people argued that this wasn't statistically a good approach to do this. When you looked at it as the pre-pathology group, meaning lumpectomy with IORT at the same time, local recurrence was 2.1% versus 1.1% in whole breast irradiation. And then the post-pathology group, there was a significant higher rate of local recurrence if you did the IORT as a separate procedure, so 5.4% versus 1.7. So this crossed the 2.5% pre-specified margin of inferiority. And actually, in this initial paper, they stated that this technique should no longer be done. There's a lot of reasons why they think that it is inferior. I mean, the radiation is very tight with low energy photons. It falls off very steeply. They could have missed the target. It could have been a matter of tumor regrowth. Who knows? So then as far as their secondary outcomes, there was no difference in overall breast mortality, and no significant toxicity differences. But they didn't really get into the details of how they measured the toxicity. So obviously there was a lot of controversy about this, and I think they brought it on themselves because of the way they analyzed the data. I think that, it is a little bit, it was too early essentially. So, there's a lot of back and forth, and I really like this quote from Anthony Zeitman that came out in the Red Journal at the time that essentially sort of put this in the category of being a religious war. Essentially, if you start to get to this point where you say this is good, you're no longer doing science. And I think that his argument was we needed to step back and think about this in a more scientific way, which I agree with. They did come up with their 10-year update. It was just published in 2020, so this year. And now they actually reported the outcomes of the pre and post-pathology strata in 2 separate publications, probably what they should have done in the beginning. The pre-path group is what I'm going to focus on because they've already published the post-path group was non-inferior, and that was what was seen in the 10-year update. So again, these women were recruited from 2000 to 2012. They now have a median follow-up of 8.6 years, and 95% of the patients have completed their 5-year follow-up. 23% of the patients who got IORT actually got whole breast irradiation. And other than the pre-specified requirements of whole breast irradiation for extensive intraductal component, positive margins, or lobular, it's not very well specified who got it and why. It is buried in the supplemental data that only 22% of the patients with grade 3 tumors, 18% of these were the ER negative, and 33% of the node positive patients got whole breast irradiation, but they really didn't do a nice post ad hoc analysis comparing risk factors to see which group was favored. But again, their primary aim was non-inferiority of 2.5%. So now with their intention to treat analysis in this post-IORT upfront study, they show again a local recurrence at 5 years of 2.11% for IORT versus 0.95% for external beam radiation. So this met their criteria. The Kaplan-Meier analysis was similar, so this is actually reassuring. And so as far as their other data, there was no difference in local free recurrence, mastectomy-free survival, disease-free survival, overall survival. They noted a mortality from other cancers was significantly lower. Personally, I think this is probably due to chance, but I'm not going to comment further on that. So their conclusions with IORT, it's a risk-adapted approach to partial breast irradiation. Upfront patient selection allows for about 75% of patients to avoid whole breast irradiation. And the 5-year ipsilateral breast tumor recurrences was non-inferior to whole breast irradiation. But this is only if you do it at the time of initial lumpectomy. The delayed procedure is definitely inferior, and no difference in breast cancer specific survival or overall survival. And they don't report excess toxicity. I think this is important because the question comes up, if you give IORT and then you give it as you end up getting whole breast irradiation, will you get more toxicity? And the papers that I've seen come out about this from the German group has been no. And from personal experience, I don't see too much excess. I don't see excess toxicity. So there always is the argument with IORT, how does, perhaps this really is doing nothing. The dose is being delivered is very, very low. Are we really giving any meaningful radiation, or is this equivalent to just breast surgery alone? So, when you put the Target A trial, especially the pre-PASS group, and compare it to studies of lumpectomy alone with no radiation in similar, slightly lower risk cohorts seen in PRIME 2, BASO 2, you can look at the 5-year local recurrence rates, and IORT does do better compared to the no radiation arm. So it seems to indicate that we are giving an effective radiation treatment. The counter argument to this is, a quarter of the patients got whole breast irradiation. How do we know that's not what's driving this down? It's, that is a reasonable argument, but I do think the data is compelling, and it makes me feel more comfortable that this is giving some radiation. And I think also with the RBE data, I don't think radiation is doing nothing. So that's quite interesting. So, what is the future of this? So I still think that, one large randomized trial is great. We've got, real data with complete follow-up at 5 years, but there's a lot of issues with how the statistics were done and how it was analyzed. So more data is definitely needed. There's the Target US trial. I think this was a prospective registry trial that was open in 2012. They enrolled 755 patients with low-risk invasive breast cancers, and they want to report primary outcomes in a multi-institutional fashion from centers in the United States. So we'll see how that data looks. And then there's other hopefully there'll be more data in the future. So to that extent, what do we do at Columbia? So to give you a little bit of background, IORT here happened because the breast surgery group bought the machine. So I arrived in 2011, and in 6 months later after I arrived, I got a call from the head of breast surgery that they had bought the machine, and I needed to figure out how we were going to use this and how we were going to implement it. So my approach to this has been, well, we need to do this on study. And so I opened a number of studies related to IORT for this reason. So the first thing we did is open Target US so that we could enroll onto that trial. We also opened an internal prospective registry for all the invasive cancers that we treat. I was constantly getting requests for unifocal small DCIS patients. Would we be willing to treat them with IORT? That ultimately led to an internal Columbia study, and which has since been brought to the SWOG cooperative group, and I'll talk briefly about that. And then I have a couple studies because of my interest in the tumor microenvironment, studying what the impact of IORT is on the lumpectomy bed. And I'm not going to get into that too much, but I'm happy to answer questions. So just overall our experience, we started delivering IORT in the fall of 2013. So as of April 2020, we've treated over 300 patients with IORT. Everybody who's treated here is on a prospective registry trial. They all know up front that this is, relatively new device with, we need to collect more data, and they understand that. So we recently reviewed our invasive cohort. These are women who have invasive breast cancers, and this is just showing who we were treating. Most of these women are low risk. Most of them are over the age of 50 with low-risk disease. We actually don't require an MRI. However, most patients with heterogeneously dense or extremely dense breasts, I do ask for it because it helps rule out patients that might have occult multifocal disease. But most of the women have low-grade tumors and hormone receptor positive disease. I think what's interesting, because we don't have a huge amount of follow-up, is how often do people switch categories? So when you think about IORT, it's a little bit difficult because what you realize is that you're stratifying patients before surgery, but you don't have all the information. And what we found is everybody we enrolled for IORT was suitable or cautionary by ASTRO guidelines preoperatively, but once you actually do surgery, there's a lot of group switching. There's a lot of stuff that you don't find out until you do the lumpectomy. And so what we ended up finding is nearly 40% of patients would switch their category for APBI suitability after surgery, with 15% on average becoming unsuitable. This is just a breakdown of why. Most of the time it was because the size was bigger than expected, or the margins were close, or we found extensive intraductal component, or LVI, or it was lobular, which wasn't detected up front. And then becoming unsuitable primarily was positive margins for like very close DCIS margins, or positive margins that need re-resection, or they became node positive. So in our experience, we generally recommend whole breast irradiation if it's bigger than 3 centimeters in size, if the margins require re-resection, or if they're very close and there's a lot of DCIS, I'll require it. LVI, I'll at least discuss it, and if they're node positive, I always require it. And our overall acceptance rate, for generally, if there is a re-excision required, most patients will accept it. So in the entire cohort, only 7% required re-excision, and it was generally accepted by the patients who needed it. Whole breast irradiation, 16% of our patients ended up getting additional radiation. Most are actually very compliant with hormonal therapy, and this is really because we asked, I really stress this. We're giving a minimal radiation approach, so you shouldn't try to be minimal with regards to taking hormonal therapy. And overall, at this point, we have a median follow-up in the entire cohort of about a little over 3 years. And our local recurrence rate, we've had 5 in breast tumor recurrences, only 2 of which are true recurrences at the lumpectomy site with the exact same, and they probably were occult residual disease that was left behind. And all 5 patients have undergone salvage therapy, 3 getting a repeat lumpectomy with whole breast irradiation, and 2 getting mastectomies. And then other events were 1 contralateral breast cancer and 2 distant recurrences. So overall, it's been acceptable, but I still think we need to do more research with regards to this. So there is a really strong demand for IORT as an option. So this is partly what's driving all of this. So we just have to continue to collect data because women want this option if it's possible. The nice thing about IORT that I do really like about it is you don't burn bridges. You can give whole breast irradiation if you find that there's high-risk features. Or what's nice is, I've had a patient who had a recurrence 5 years later of a new breast cancer in the same breast, and she got a lumpectomy and whole breast irradiation, and she's grateful she didn't need a mastectomy. But we clearly need more data. So, and then there's this whole question about DCIS, which constantly comes up. You get these women with these teeny tiny unifocal DCIS. They really want IORT. So we had to do something about this because it kept getting pushed on me. So what ended up happening is I developed a study, an institutional study looking at low-risk DCIS at Columbia, and this ultimately got proposed to SWOG and has been accepted by the prevention committee, and we are now moving, it's been accepted by this, has gone through triage and is being promoted through SWOG as SWOG 2003. And we're going to present it to DCP this next month. But essentially, it's a phase 2 study to evaluate local recurrence following IORT for low-risk DCIS after breast-conserving surgery. And our goal is to prove that this is that IORT is better than breast-conserving surgery alone. Essentially, this is a futility trial, and DCIS is a nice opportunity because with DCIS, while radiation prevents local recurrence, it has no impact on overall survival. So if you picked a low-risk cohort, it's IORT essentially, if it really is doing nothing, this is an opportunity for us to almost prove that because we can set our pre-specified boundaries to say that IORT we can say whether or not it's better than breast surgery alone, and because ECOG Akron has very good data, and the RTRG 9804 also has very good data for low-risk DCIS, we know what the expected rate of local recurrence is at 5 years with breast surgery alone. And our primary outcome is local failure, either DCIS or invasive breast cancer at the lumpectomy bed, calculated out to 5 years. And our hypothesis is that it will be better than surgery alone compared to historical data. And we're using a futility design. So this was great because I actually was doing the master's in biostatistics, and there's actually this design was developed at Columbia, and it's used primarily in the pharma industry to rapidly test new therapies compared to control, especially in diseases where there is no therapy. So the person who developed it looked at Alzheimer's, and there is no effective therapy. So you can set you're comparing it to doing nothing, and that's really what we wanted to do, is IORT, can you compare it to doing just lumpectomy alone. And what you do is, if you reject the null hypothesis, you pre-specify that the treatment is better than doing nothing. But if you reject that hypothesis, then it's considered a futile treatment and you should not pursue it further. So essentially this is how the design is set. So it allows you to rapidly test with fewer patients whether a treatment has promise. So we know, based on the ECOG trial and RTOG trials and other randomized trials, what the expected rate of local recurrence is for DCIS for well-selected patients with lumpectomy alone versus with whole breast irradiation. So for the low-risk group, it's 6% with surgery alone at 5 years versus less than 1%. For cautionary group, it's 15% versus 6%. So you have to set a pre-specified minimal improvement, sort of inferiority compared to IORT compared to whole breast irradiation, because you know that it can't be better than IORT, whole breast irradiation. And so we said that it's acceptable for the low-risk group as long as IORT had a recurrence rate of 2% or less, for the cautionary group of 9% or less. And this will allow us to see if IORT is better than nothing alone. That's my hurry up and finish. So, using this technique, it allows us to design a single-arm study with a small number of patients. We need about 200 in the low-risk group, 250 in the slightly higher-risk group to test our hypothesis. And so this is how the study is designed, is that we're allowing women over the age of 40 with screen-detected unifocal DCIS, exactly matching the entry criteria to ECOG Akron, and they all would get surgery with IORT, and then post-pathology they would get stratified into 3 cohorts: suitable, cautionary, or unsuitable, based on their final pathology. If they're unsuitable, we are recommending whole breast irradiation. We don't know, it's not going to be required. We're interested to see how many patients will accept it. And then our primary outcome is to look at local recurrence. Now, this has already gone through Bold Committee, and the suggestion was that we not limit it to a single device. So it's difficult to look at both electrons and low-energy photons, so we're only looking at low-energy photons, but we're allowing study centers to use either the Zoft or Zeiss systems. And post-pathology will define their stratification. And if they need whole breast irradiation, it's 40 gray and 15 fractions. And then secondary aims are to look at how often we get monotherapy, patient-reported toxicities, frequency of physician-reported toxicities, as well as photographic assessment. And then we have a really nice translational outcome looking at a biomarker, a DecisionRT tool, which is used to determine the benefit of radiation with lumpectomy alone. It's never been looked at in the setting of partial breast irradiation. I think this is a nice opportunity, and the company was interested in doing this. So final conclusions. Partial breast irradiation is non-inferior to whole breast irradiation. If you are giving it with external beam, the once-a-day regimen as per the Florence trial is the preferred technique, though the toxicity compared to hypofractionated whole breast irradiation is not known. And then patient selection is key, and it's likely we're going to see an update in the criteria probably in the next year or two, I'm sure. And the role of biomarkers for patient selection, I think, will be really interesting in the future. And then IORT, it's obviously very controversial, but I really think it's worth studying it. If we're going to do this, we should do it in a systematic, scientific fashion and prove that there's a benefit. And this is everyone I'd like to thank. I've worked with a lot of people here at Columbia, as well as in SWOG, who've helped me with all my work. And thank you, and thanks to David for inviting me. So I think I have to stop.
Thank you so much, Dr. Connolly. If you have, excuse me, if you have any questions, please use the Q&A feature located at the bottom of your screen. While we wait on questions, please plan to tune in next week, as our Grand Round speaker will be Dr. Joanne Zajewski, who will be presenting the role of neoadjuvant chemotherapy for breast cancer in 2020. We're sticking with the breast cancer theme here in October. To view all upcoming Winship Grand Rounds lectures, please visit the Grand Rounds page on the Winship Cancer Center website in the Winship calendar. And I see some questions populating.
What do you think the riot? Okay. Oh, so Mylin asked, what do you think is the radiobiological rationale for IORT versus fractionated external beam radiation? So I guess you're asking sort of how are they possibly equivalent? I mean, I guess this is, so it's the idea is if you get, I almost kind of think of it as SBRT. If you think that, if you believe the RBE data that low energy photons are actually have a higher RBE of direct DNA damage, theoretically, we're delivering a much larger dose to the lumpectomy bed on the order of about 9 to 12 gray at 1 centimeter. At the surface, it's actually calculated between 25 and 30 gray when you look at it, which means that you're giving a much larger dose. And if that is really where your limited microscopic disease is left, this is much more equivalent to you know, a high SBRT dose. So that, I think, is why potentially it could be effective. Additionally, it may affect cytokine profiles of the tumor cells after, you know, after the treatment and that changing the microenvironment. Right. Right. So yeah, this is the other thing is in the post-pathology. So when you do a delayed IORT, I do think that's actually really interesting because there's a few studies that have looked at, so again, Mylan asked about what do you think of the post-pathology data, that growth factors flood the cavity and mitigate the impact of IORT. I actually think that's probably very, very true. And I think it's really interesting because there are studies that have looked at the lumpectomy cavity and the fluids comparing fluids with and without IORT. And if you do an immediate IORT procedure, you actually see a very different cytokine profile. And they've looked at 2 weeks later, 1 month later, compared to patients who never get IORT. And I haven't actually seen the direct data in terms of the post-pathology lumpectomy cavity, but I imagine what's happening is that you've already shifted the response and it may be too late for the radiation to be effective. I mean, that's possible. Again, another reason why post-lumpectomy as a second procedure is not effective. Though I also think you could easily miss the target. I mean, that's the other possibility. I think that's it.
I think we've oh, I think one more just popped in. Mylan's on a roll.
Oh, okay. Oh, okay. So when we re-excise, so if patients have a positive margin, they have to go back to the OR. We actually give them whole breast irradiation because at this point it's like they've essentially removed the entire lumpectomy bed. So there's really no way to say that what we've done has any effect, and that's pre-specified up front. All our patients know that. I've only had maybe 2 patients who declined, and those are women who are, you know, elderly or have comorbidities and frankly could have just gotten away with lumpectomy alone. But all of the younger risk women who, if they need to go back, they already know up front. And I typically give them 40 gray and 15 fractions, and it's very well tolerated.
And then any issues with complications?
The main complication we see with IORT is seroma formation, and they do see that. So typically with lumpectomy alone, the expected rate of a symptomatic seroma is about 1%. And our experience is probably closer to 2 to 3% after IORT, and that's consistent with what the literature that you see out there. Most of the time, it's just managed clinically. Infrequently, they need to drain it. Occasionally, it can become a problem, but it's not a huge problem, but that's the main difference that we see that can be an issue.
Okay. Thank you, Dr. Connolly. This was wonderful. We really appreciate it.
Yeah, thank you so much for inviting me. It was really nice.
Absolutely. Have a great one.
Okay, you too.